So welcome to this next session in the course on cluster randomized designs in cancer care delivery research. So in this session, we are going to look at some implementation and design-based considerations. So as a quick recap then, we've learnt that cluster randomization increases the required sample size and the risk of bias. So there should be a general preference towards using individual randomization wherever possible. Now, sometimes individual randomization will not be possible. So for example, if we're evaluating a cluster level intervention, or perhaps we're interested in direct and indirect effects. Now, when cluster randomization is used and is adopted with appropriate justification, if it includes any post-randomization recruitment, then those who are identifying and recruiting the participants into the trial should be blind to the treatment allocation. In addition, we've also learned that the stepped-wedge cluster randomized trial increases the complexities of running the trial. It's slightly at increased risk of bias compared to the parallel design. And so therefore, in addition to having to justify the choice of cluster randomization, investigators and practitioners should also very carefully consider and justify the choice of a stepped-wedge design over a parallel design. So in this session, we're going to assume that cluster randomization is necessary. And then given that a cluster randomized design is going to be adopted, we're going to think through some of the very practical choices that can influence its design. So we're going to look at the choice of the cluster, some common design variations, including staggered starts, what we call staircase designs, and baseline periods. We're also going to think about the importance of transition and washout periods. How do we choose the number of sequences or the number of crossovers? And how do all these other choices and all these choices that we're going to consider influence the duration of the study? We're also going to consider briefly some related design choices, including something known as the hybrid design, and we're also going to think about how pilot and feasibility studies might be helpful. Now, in this session, we are going to be considering practicalities around design choice. Of importance is also statistical efficiency, and we're going to be looking at the importance of statistical efficiency and how statistical efficiency also changes with these different design choices in session 4. So remember that cluster randomized trials can be used to evaluate different types of interventions. So for example, they might be used to evaluate something called cluster level interventions. So these are interventions that are delivered at the level of the entire cluster. So for example, some high-level change to the electronic healthcare record. They also might be used to evaluate professional level interventions. These are delivered at the level of the healthcare professional, and examples include things like education or training. But cluster trials can also be used to evaluate individual level interventions. And these are interventions that are delivered directly to the individual patients. So for example, drugs. Now, of note and of importance is that the unit of clustering refers to the unit of randomization, and this might well be different to the unit at which the intervention is delivered. So some examples of clusters or randomization units include such things as region or city or area when we're randomizing at the level of the geographical area. Other examples include such things as primary care or the general practice, secondary level of care or ward, school or class, if we're randomizing institutions. They might also consist of teams of healthcare professionals or health professionals themselves when we are randomizing at the level of the healthcare professional. Or randomization or clustering might represent such things as a weight management group or maternity group in other settings. Now, the level of randomization can and is often different to the level of the intervention. So on the left-hand side is an example where the unit of randomization is different to the unit of delivery. So in this example, the PSA screening trial, an example that we've looked at earlier, the intervention is a PSA screen. This is given directly to the individual participant, so the individual is the direct recipient of the intervention. The unit of randomization, however, is the general practice, therefore an example of where the unit of randomization is different to the unit of delivery of the intervention. On the right-hand side, an example where the unit of randomization is the same as the unit of delivery. So this example is an evaluation of a decision support system in the ER department. The physician is the direct recipient of this intervention because he is provided with these support tools. And the unit of randomization also happens to be the physician. So an example where the unit of randomization is the same as the unit of delivery. Now there are trade-offs to be made when we're choosing the level of the randomization. For example, we might choose to randomize at a lower level. So we might choose to randomize classes, schools then become a higher level of clustering. We might randomize wards. Hospitals then represent a higher level of clustering. Or we might randomize general practitioners. The general practice then represents a higher level of clustering. Alternatively, we might randomize at a higher level. So we might randomize schools. Classes then represent a lower level of clustering. We might randomize hospitals. Wards then become a lower level of clustering. Or we might randomize general practices. General practitioners then become a lower level of clustering. Now the choice of cluster for randomization involves typically trade-offs between logistics, statistical efficiency, and contamination. And we'll have a look at all of these things over the next few slides. So let's think first about logistics. So logistics refer to the ease at which the trial processes can be implemented. Now, logistics are likely to be enhanced when there are fewer clusters that need to be enrolled or exposed to the intervention, and the intervention can also probably be delivered then in a more controlled way. So an example of a logistically feasible design might be in the setting where an intervention is delivered just to a handful of schools. So it turns out that logistics are often enhanced when we're randomizing at a higher level. So for example, if we're randomizing hospitals rather than wards. Contamination refers to the control participants inadvertently receiving the intervention condition. Now, contamination is more likely to arise when the intervention and the control participants mix, or the intervention is available outside the trial. So examples of where contamination might arise are, for example, where we might randomize class, and there might be mixing across classes within a school. Or we might randomize at the level of the ward. Doctors might work across multiple wards within hospitals. So contamination is likely to be reduced when we randomize at a higher level. So for example, if we randomize hospitals rather than wards. Statistical efficiency refers to the amount of statistical information that is available from the data or the outcome observations. And statistical efficiency is often maximized when there are a greater number of clusters. This essentially increases the independence of the data. So some examples of statistically efficient designs includes where we randomize a large number of general practitioners or doctors, or we randomize many classes. So it turns out that statistical efficiency is often increased when we randomize at the lower level. So for example, we randomize wards rather than hospitals. So let's work through these considerations in a practical example. Let's consider the choice of whether we should randomize the general practitioner or the general practice. So on the left-hand side, let's think through what would happen if we chose to randomize the general practitioner. Well, there tends to be more general practitioners. This will mean that we have more randomization units, and there will be greater statistical efficiency, which is a good thing. But on the other hand, there may be a greater risk of contamination. So many GPs work within the same general practice, and the interaction between those GPs might lead to sharing of the intervention. So that's not a good thing. In addition, randomizing individual GPs might increase the logistical complexities of the trial design. On the other hand, if we were to randomize at the level of the general practice, we would probably find we had fewer randomization units, and this would lead to a reduction in statistical efficiency. But we would probably be at a reduced risk of contamination, so GPs work perhaps mainly within one general practice, and there might be minimal interaction between the different practices. Logistics will also probably be enhanced when we randomize at the level of the general practice rather than the general practitioner. There are also some other extra considerations that we might need to consider. So we thought about the choice of clustering between hospital versus ward, general practice versus general practitioner, school versus class. But there are also considerations with geographical choices. So for example, town versus area of a town. And here some extra considerations might need to be thought about, especially when those geographical areas represent close clusters. Here, contamination might arise. So in this example here, village was the unit of clustering or the unit of randomization. And the villages were chosen with a restriction that they had to be more than 5 kilometers distance apart from one another to prevent contamination. So in general then, there is a trade-off in the choice of cluster. If we randomize at the lower level, we tend to have more clusters in our trial, and this will increase the statistical efficiency. But it will also induce a higher level of clustering, which probably will lead the trial to an increased risk of contamination. And logistics will probably be increased because of the increased complexity with having many randomization units in the study. On the other hand, if we randomize at a higher level, we typically will have fewer clusters in our trial. This will lead to a reduction in statistical efficiency. Minimal higher levels of clustering will probably lead to a reduction in the risk of contamination, and logistics will probably be improved with reduced complexity in running the trial. So let's move on to some other considerations. So we're going to consider these other considerations in turn over the next and subsequent slides. So we're going to think about the need to allow for sequential recruitment of clusters, how we might maximize efficient data collection, how many crossovers and how many periods we should include in our design, how many clusters should be allocated to each sequence, and are washout periods and transition periods necessary, and if so, how long should they be? So staggered starts. So staggered starts allow clusters to enter the trial sequentially, and they also allow the intervention to be rolled out sequentially. So stepped wedge trials are often considered to be advantageous because they are very pragmatic and they allow the rollout of the intervention in a staggered way. However, in fact, almost all cluster trials allow for staggered starts. So the parallel trial does, the parallel cluster trial with a baseline, as does the stepped wedge, as does the cluster randomized crossover design. We're going to have a look at some examples of staggered starts across a range of cluster trials over the next few slides. So first of all, an example of staggered starts in a parallel cluster trial. Staggered starts are important because cluster-specific approvals can take time. So for example, imagine running a trial with 50 hospitals. The site approvals for those 50 hospitals might take a considerable amount of time, and clusters will probably end up being ratified for study participation sequentially over several months. Now, in a parallel trial, cluster trial, each cluster can initiate the study sequentially, and they can be randomized as and when their participation is ratified, just like how patients enter a randomized trial sequentially. So these staggered starts allow for both the sequential cluster recruitment, but they also allow for the sequential rollout of the intervention. So the emotive trial implemented staggered starts and staggered rollout of the intervention. It was a parallel cluster randomized design, and it reported this very clearly. So on the right-hand side here, we have a schematic illustration of the emotive trial. The green represents the clusters allocated to the control arm, the orange, the clusters allocated to the intervention line. intervention arm. And these steps here represent the sequential and staggered allocation of the clusters into control or intervention condition. And the blue represents some sort of transition or embedding phase when the intervention is embedded into those clusters. So clusters start the study sequentially, and the intervention is rolled out sequentially across the different clusters. Now, it usually goes unreported in most parallel cluster trials, but it's very common practice. So parallel cluster trials allow clusters to start the trial sequentially and can also allow the intervention to be rolled out sequentially. On the other hand, whilst the stepped-wedge cluster randomized design allows for staggered rollout of the intervention, it does not allow for clusters to start the trial sequentially. So here on this schematic representation, our clusters are allocated to a sequence and the intervention is sequentially rolled out into all of the clusters. But all of the clusters must be available at this point in time for trial participation so that they can contribute data to the control condition in each of these periods here. So, although the stepped wedge trial is appealing because it allows the intervention to be rolled out sequentially, it doesn't allow clusters to initiate the study sequentially. Where clusters are not all available for randomization at the start of the design, something called a batched stepped wedge cluster randomized trial is an alternative option. So this is the batched stepped wedge trial. It's essentially a series of mini stepped wedge trials. Now each mini stepped wedge trial is run independent to the others. So here's one mini trial, here's another, and here's another. It's a much more flexible design because it allows what we might call the highest risk clusters to be randomized in this first batch here. So imagine that you're working with some stakeholders who find this intervention very appealing, even though it has yet to be evaluated. But nonetheless, because stakeholders find this intervention very appealing, there is a strong desire for what we might call the highest risk clusters to get the intervention first. So stakeholders want these highest risk clusters to go in the first batch of the rollout. Now this design allows for that because the highest risk clusters can be put into this first batch or first mini stepped wedge design, but then randomized to one of these three different sequences. And then the lower risk clusters can go in the next batch, and then the very low risk clusters could go in the next batch. Now, there's a cost to this enhanced flexibility, and that is it increases the study duration. But it does allow clusters to start the study sequentially, and it allows the intervention to be rolled out sequentially, which can be very important logistically. The staircase design is what we might call an incomplete stepped wedge trial. It can be very statistically efficient when there are resource and cost implications to collecting data from all the cluster periods. It allows staggered rollout of the intervention, but it does not allow clusters to start the study sequentially. So here's an illustration of a staircase design. We've got our 10 clusters here that are actually called cohorts in this particular schematic. For a period of time, each of the clusters is observed under the control condition, and then the clusters are randomly allocated to transition to the intervention condition, where they are observed under the intervention condition for a period of time. Now, in a typical stepped wedge trial, all of the data would be collected in this area here and also in this area here. It turns out that focusing the data collection in the middle part of the design, at the point where the clusters transition up to the intervention condition, is actually a statistically efficient design. So this can be an appealing choice in some settings. The intervention is rolled out sequentially, which is appealing in many settings, but again, clusters have to start the study at the same point in time because they have to all be available to be randomized to any one of these particular sequences. So although the intervention can be rolled out sequentially, clusters cannot start this study sequentially. Staggered starts can also be accommodated in cluster crossover designs. So clusters often in practice initiate their assigned sequence as and when they are ready to start participation. So it allows for staggered starts. In practice, cluster trials are not as neat as they are often designed, and in practice they might look more like the study on the right-hand side. It's important to make sure that clusters are randomized to what we might call the dual of sequences, the opposites of the sequences, to prevent temporal biases. So as and when clusters are ratified for participation in the study, they are randomly allocated to one particular sequence, so either 2 periods exposed to the intervention, 1 period off, 2 periods on, 2 periods off, and so on. But they are allowed to start their sequence as and when their participation in the study has been ratified. So it allows clusters to start this study sequentially, but it doesn't allow the intervention to be rolled out sequentially. So let's move on to a few other questions now. So one common question is, how many periods or how many crossovers should we include in our study? So when determining if it's possible to have many crossovers, logistical considerations are often very important. So in a stepped wedge trial, the more steps that we have, funding restrictions might mean that the duration of the study is limited, and this might prevent the staggering of the rollout to more than one cluster at a time. On the other hand, if we have fewer steps or fewer crossovers in a stepped wedge trial, we're then often faced with the challenges of rolling out the intervention to multiple sites at the same point in time. And in a cluster crossover design, the more crossovers we have, this can often increase the logistical challenges. So there are often many practical considerations with thinking about how many crossovers should our design include. There are also statistical efficiency considerations when choosing the number of crossovers or the number of sequences. We'll look at these again in session 4. How many clusters should we allocate to each sequence? So stepped wedge trials do not have to have just one cluster allocated to each sequence. Now, if we have a design with fewer periods, we will then include more clusters per sequence. So as in this example here, we only have 3 sequences, 4 or 5 periods. So many clusters have to be allocated to each of the different sequences. So between 27 and 30 clusters have been allocated to each of our sequences. This probably reduces the duration of the study, but it will be necessary to roll out the intervention to around 30 clusters each of these different steps. And that can be logistically challenging in some settings. So the fewer sequences we have, the shorter the duration, but the more complex it often turns out to be to roll out the intervention to many clusters at the same time. We can also have a varying number of clusters allocated to each of our sequences. So it's often not the case that the number of clusters in our design will be a nice even multiple of the number of sequences. So in this example here, we see that there are 11 sequences, and there are between 5 and 22 clusters allocated to each of the different sequences. We also can include something called a baseline phase in a parallel cluster randomized design. Now, the duration of this baseline phase can be increased if we decide to use retrospective data. So cluster randomized trials with baseline phases do not have to have an even split of observations collected in the pre and the post rollout phases. Now, when outcomes are based on routinely collected data, it can be very efficient to use this historic or retrospectively collected baseline data, so long as the data collection has been reasonably stable over time and we don't anticipate any changes with the way that the data has been collected over the duration of the trial, else these data here will not be comparable with those data there. Transition and washout periods are periods of time in which the intervention is embedded or rolled out. Now, in stepped wedge trials, these are often referred to as transition periods, but in cluster crossover designs, we often refer to them as washout periods. The duration of these washout and transition periods will depend on the time needed to roll out this intervention and allow any of its impacts to materialize. This depends on what the nature of the intervention is and the logistics of setting the intervention up in place. Now, in these transition periods or washout periods, the data on the outcomes may still be obtained, and it's often better to keep eliciting outcome data collection to not disrupt the trial processes. But it shouldn't be included in any analysis, as they will represent periods of time in which the intervention has not been fully embedded into practice. So here's an example of a transition or washout period in a cluster randomized crossover trial. So we've got our different sequences down here, and the different shades of blue represent different intervention, different treatment and control conditions. Each of the clusters is experienced for a period of time, and then a 1-month transition period is excluded from the analysis or included in the trial design to allow the clusters to transition between the different intervention conditions. These transition periods can also be incorporated into cluster randomized trials with baseline periods. So in this trial here, the green represents the control condition, the orange the intervention condition, and the blue here a transition phase, when each of the clusters transition from their control to intervention phase. And then finally, an example of a transition period in a stepped wedge trial, represented by these darker blue cells. So transitioning between control and intervention condition. Now, one of the final things to consider is the duration of the study. So the duration of the study depends on many things. It depends on how long the transition period is, whether there are any staggered starts, how long each period is in the design to allow the enumeration of the required sample size. And it also depends on how long participants will be followed up for their outcomes, even though this is not usually factored into schematics. So the duration of the trial is often represented in the schematic illustration, excluding the follow-up. But when we factor in follow-up from the outcomes, the duration of the trial can, and often is, much longer than that represented in the schematic illustration. Now, a couple of final things. Pilot and feasibility studies tend to be mini versions of the main trial. They can be used to develop or tailor the intervention, test its acceptability, and also to test the trial protocol. So depending on the objective, so for example, if the objective is to develop or tailor the intervention, the design that we use at the feasibility stage does not necessarily need to match the study design of the anticipated definitive trial. In most situations, pilot and feasibility trials should not be used to estimate either the effect size or to estimate the intra-cluster correlation, except perhaps in some rare circumstances where the ICC might be very high. There's either a very large number of clusters or a very large cluster size. And this is because estimates of both of these things from pilot and feasibility study tend to be so imprecisely estimated that they end up being uninformative. Hybrid designs are used where we are interested in evaluating not only the effectiveness of an intervention, but also the implementation of it. There are a number of different types of hybrid designs, depending on whether the primary objective is to consider implementation type outcomes, or whether the primary objective is to consider effectiveness type outcomes. So implementation outcomes are often and can be important in these types of designs, and then we end up running what's called a hybrid design. So in summary then, in this session, we've considered some very practical choices that we have to think about when choosing or setting up our cluster trial. So we've thought about the choice of cluster, which effectively means the unit of randomization. We've considered the impacts of staggered starts, transition periods, washout periods, how many clusters we should have per sequence, how many periods we should have in our design. Now, we've only considered thinking about these choices from a logistical perspective in this session. But these choices also have important influences on study power, or what we might call statistical efficiency. And we'll come back to looking at these again in session 4. We've also considered some related designs, hybrid designs when we're interested in implementation outcomes, and pilot and feasibility studies where we might want to develop our intervention or test our trial processes before we get to our main trial design. And perhaps of important note, pilot and feasibility studies do not have to take the form of a cluster trial, even if the definitive trial will take the form of a cluster design. So here are some of the methods references that have been cited in this section, and references of some of the actual studies that have been cited. And up next in session 3b, we're going to think about different randomization methods.